Okay, so I'm Angela Sanford, and I am a geriatrician, and I think I know pretty much everyone here. But I apologize if some of you have seen this lecture. This has sort of been on my traveling circuit, so I apologize. I did it at boot camp, so a couple of you might have seen it there. But we're going to talk about hip fractures in the elderly. I got interested in this lecture when we started doing the hip fracture study at SLU, which is now, we're finally finished with recruitment on that, and we're just kind of into the follow-up maintenance phase of that study. But I realized that I didn't know the best practices for hip fracture management, and I decided that I needed to learn them so that I could better educate the residents and the students in how to manage these patients so that we would have good outcomes for our study. Okay, no financial disclosures. Ortho got paid, but we did not for that study. So we'll start with a case presentation. We'll talk about hip fractures. We'll talk about best management and treatment practices post-hip fracture. And I just put a couple slides in about the study. Okay, so for our case, this is a real case, a lady that I took care of when I was on ACE over a weekend once. So it was an 83-year-old female who presented for fall with left hip pain. She was getting up to go to the bathroom in her assisted living overnight, and she tripped and fell. She laid on the floor for about 2 hours before she crawled to pull her emergency cord in the bathroom. Once she got to the hospital, she was found to have a left intertrochanteric fracture. Ortho was consulted and wanted to take the patient to the OR in the AM, but need medical clearance. So unfortunately, there's no students or residents because this is a common occurrence, right? They want to take, oh, I get a visitor. No. No. Okay, they often want to, ortho calls us at like 7 a.m. and wants to take the patient to the OR right now. So we'll talk a little bit about how do we provide medical clearance. Okay, so past medical history is significant for dementia, hypertension, coronary artery disease. We never did really get an idea of what happened, why she carried that diagnosis, recurrent falls, and osteoarthritis. So medication, she's on medical management for CAD. She's on some meloxicam for arthritis and Aricept and Namenda for dementia. Social history, lives alone in assisted living. She's widowed with 4 grown children. She uses a walker. Fairly independent with ADLs, needs some assistance for safety reasons and fall risk, but she's dependent with her IADLs. She only drinks alcohol at the monthly assisted living happy hour where there's a 2-drink maximum. We actually have those at my assisted living. Really, really a fun time. This patient's fallen 4 times in the last year. So family history, father died of TB, mother died of old age. So review of systems positive for left hip pain, back pain, constipation, dizziness, and particularly lightheadedness on standing. She doesn't climb stairs because of the arthritis in her knees, and assisted living's all on one floor. And we ask that question because it helps us with our functional assessment when we're doing our medical clearance or risk stratification. So physical exam notable for bradycardia and hypotension. She's got a 2 out of 6 systolic murmur at her right upper sternal border. I couldn't find a picture of the left hip fracture, but we'll just pretend that shows that the left leg is shorter and externally rotated. She's got a little bit of swelling over that left foot. So her lab work was all normal except for a low sodium of 133 and a hemoglobin of 10.7. Her creatinine was 1.5. It was the first time she'd been to SLU, so we didn't really have a baseline at that time. And then her x-ray showed a moderately displaced intertrochanteric fracture. So what do you think may have contributed to this patient's fall based on her history and her medications? Unfortunately, there's no students, so it's you guys, the experts, I'm asking. Yeah. Yep. Some other thoughts I thought about, low vision, I don't know, and she fell at night. Was it appropriately lit? Let's see.
And she has osteoarthritis, so she has
right.
musculoskeletal issues that are including her safe ambulation.
So lower extremity weakness, gait unsteadiness. Dementia, is she demented? Did she forget to use her walker? Did she trip over her slippers next to the bed? And how do we provide medical clearance, aka risk stratification for surgery? Because ortho's ready to take her. So what's our answer to them? Is she ready to go, Dr. Hassan? Should I just write in my note? Yep, patient cleared.
That or she won't walk again.
Right, but that's not really an acceptable note.
You shouldn't look too hard to find a reason not to go.
Okay, so
However, but how you
So we'll talk a little more about cardiac risk assessment because I think this is important. We get asked this question a lot, and I think we as geriatricians go about it the right way. It's other people that may not agree with our views. Whenever I give this lecture to the residents, they kind of argue with me about it, that we simplify it. But so in 1970s, Goldman came out with the first cardiac risk index. And you'll see some kind of strange things that we don't now find important, like, does the person have greater than 5 PVCs per minute? That's not something on our, our current risk assessment. But basically, he found these factors and risk stratified the patients into 4 risk categories based on these 9 clinical risk factors. So this was the original cardiac risk index. And then sort of our thinking evolved over 30 years, and then in 1999, the revised cardiac risk index, the RCRI, was developed. This is what we use now, and so it's simplified. It sort of makes sense. It was developed from independent predictors of adverse perioperative cardiovascular events. So they did this retrospective chart review in patients, in 2,800 patients, and looked to see what were markers of bad outcome post-op, what were bad cardiovascular markers. And this is what they came up with. And then they prospectively validated it in 1,400 patients. So again, they're risk stratified into basically 4 categories based on their risk. We also often talk about functional capacity, and in fact, this actually may be more important than the revised cardiac risk index. So functional capacity is expressed in metabolic equivalents, or METs. And this is an estimate of energy expenditure for common activities relative to one's resting metabolic rate. So what would you think our patient, what would you say our assisted living patient here, how many METs do you think she would meet? Yeah, I was thinking probably 3, maybe 4 if we're lucky, but she's probably not climbing stairs, so probably around 3. I would guess she's walking with her walker, to the dining room and such. Patients with excellent functional tolerance are unlikely to experience adverse cardiac risk or events, even with risk factors. Pardon me?
You can do it now. It's over.
Everybody's going to sleep. I think you've all seen this enough times that you probably could give it, so. I can't tell where the lights are. Okay. So I think in terms of like your avid golfer who had a cabbage, he's probably more functionally fit than, this assisted living patient without many risk factors, but who has no functional capacity. So we really think that functional capacity is probably more telling than actual risk factors alone. So in terms of an algorithm to follow, let's start with our patient on step 1. Does she need emergency non-cardiac surgery? Let's say no, it's not emergency. Does she have active cardiac conditions in step 2? Let's say no. A low-risk surgery, it's really not a low-risk surgery because it's done under an urgent condition. So we'll proceed to step 4. Does she have good functional capacity, at least for METs? Probably not. She's probably at 3, so we'll go down to no on step 5. And then this looks at risk factors. So how many clinical risk factors? We decided she probably has 1 to 2 clinical risk factors. So that middle box there, and it's an intermediate risk surgery. It's not vascular. So it says we're supposed to proceed with planned surgery with heart rate controls or consider non-invasive testing if it will change management. That's the key that I think we often don't take into account. Will it change management? And we just sort of order things like echoes and stress tests and such. So in terms of non-cardiac procedures, technically our surgery is probably urgent. We need to get this hip repaired ideally within 48 hours. So it would be technically stratified as a high-risk surgery because it's urgent, just by nature. Other preoperative predictors of overall mortality and morbidity, not just cardiovascular events, low creatinine clearance or renal failure. Dementia independently predicts increased mortality, low serum albumin or malnourishment, and then prior level of function, were they independent with their ADLs and IDLs? That will definitely depict what will happen after surgery. So hip fracture surgery is considered intermediate to high risk. It's an urgent procedure, usually in the setting of trauma. So this lady laid on the floor, her creatinine's a little elevated, she's hyponatremic. What happened to her before that caused her to fall? So it's definitely a traumatic event, so it's a higher risk by definition. Older patients are more likely to have more risk factors and other comorbidities. They're also more likely to be functionally and mentally impaired. So falls in itself are predictors of frailty and geriatric syndromes, and those are independent predictors of poor outcome. So let's talk more about our case, because it definitely gets more complicated. I think you guys will all appreciate this. So someone was concerned that the patient was bradycardic and had a heart murmur, so a cardiology consult and echocardiogram were requested. But the patient came in, unfortunately, on a Friday morning, which is probably the worst time to come to Slough Hospital. The echo wasn't done until Monday afternoon, and then by Monday, she had been in bed for over 72 hours, and her left lower extremity was extremely edematous. A Doppler was ordered and done on Tuesday and was positive for a DVT. So then the team was stuck. They had to schedule her for an IVC filter placement, but she got bumped because they put preference, IR puts preference on outpatients, so the IVC filter wasn't done till Thursday. So her hip fracture was finally repaired on Friday, a week after admission. The surgery was uneventful, she did fine, and rehab placement took several more days. On the day of rehab, which is actually the day I started service, on the day of rehab placement, we came to see her and she was more confused. She didn't know her name. The residents told me this was not her. So we did a UA and it revealed a UTI. And the rehab doctor said they don't take patients unless they've been on antibiotics for 48 hours and her confusion is cleared up. So she was in the hospital for a week and a half. So my question to you is, did this patient's stay have to be so long and complicated? And what do you think we could have done differently? Again, this lecture is more geared towards students, so you guys know all the answers. Right, so did she need a cardiology consult? Did she need an echocardiogram? It was so insignificant, whatever the echo showed, that I don't even remember the results. I remember the case well, but I don't even remember what the echo showed because it was nothing. The other thing I thought of is, I don't know, did she get her UTI because we left her Foley in too long post-op? I don't really know.
So Angela, the only thing that shows really bad outcomes for hip fractures is if you have a cardiologist see the patient. That's true. It's good literature. The literature does exist, and the reason is because exactly what happened here. They always order things, and so the bottom line is they are fit for surgery unless you think they're going to die instantly. And that's how you handle it. So you get rid of all the junk there, because if you look at the junk, then you start to worry and you may get a cardiologist. So if you don't listen to the heart, you don't do anything. I mean, the way I do fit for surgery for hip fractures, I walk into the room, if they can talk to me, I say they're fit for surgery, and that's it. And it actually works, because if you do all the other, you start to have to second guess yourself. Not you, because you do it well, but for the average physician, they second guess. And obviously somebody second guessed all sorts of people. Yeah.
I think Dr. Flaherty one time emailed me for these slides, and I sent it to him, and then a couple days later he told me that this same kind of thing happened to him on service. And he looked at my slides and he went and talked to Dr. Chapman, the cardiologist, and who's like the expert and all that. And so he went through some of this like non-invasive testing and all these studies that I'm going to show you, and he backed Dr. Chapman in a corner, but he still couldn't say like you shouldn't do them. Because Dr. Flaherty kept saying, well, if you do this test and it doesn't change your management, why are you doing the test?
That's why you use for hip surgery the study that showed cardiologists are dangerous to patients. And it's a very good study. That's the reason. It's simple.
Okay, so.
Not have a cardiologist near, most probably any old person, but in this case it could be.
So let's talk a little bit about non-invasive cardiac testing. So our big question here is, will the results of the test, whatever it may be, the echo, the stress test, whatever, change our management? And if positive, what are our options? So what are we going to do? Are we going to do a CABG in this patient? Are we going to do a stent? Are we going to optimize their medical management? Right. So based on our revised cardiac risk index in this patient, I think we said she probably got about 2 points, and that would give us no test in medical management only. And she was already on medical management. So they did this trial at the
To be fair, there are in fact some cardiologists in the community, when they get a patient like this, if they think they've had an MI, they will actually stent them so they can go to surgery the next morning. So they'll do it as they come in, and then they can go straight to surgery. That's basically the only time I think the cardiologist
Let's talk about the CARP trial. So actually, I think I stole this slide from Dr. Roten. So the CARP trial was a trial that was done at the VA. It was a randomized controlled trial involving 17 VAs, and these were basically patients that were scheduled to undergo elective vascular surgery. So we know the vascular surgery is really the highest risk surgery. So they took patients with stable but significant CAD, and they randomized these patients, scheduled to undergo this surgery to revascularization pre-op versus medical management. And most patients, again, had pretty significant disease with a revised cardiac risk index of greater than 2. And they found there was no difference in 30-day or 2-year mortality. So it really didn't make a difference if they put the stent in. What really happened is that the vascular surgery was just delayed in the patients that underwent their CABG or stent placement. So stents may increase your risk immediately afterwards of in-stent thrombosis. So it's not clear how long to wait after PCI for surgery. Most studies suggest waiting 6 months, but really we don't know. And then, of course, there's always the issue of when to stop the anticoagulation. Is it safe to stop the Plavix and the aspirin? So hip fracture surgery is considered emergent, and preoperative cardiac testing is typically of low predictive value. And then, of course, we know perioperative beta blockers are only indicated if they're indicated anyway. And then no evidence that urgent revascularization benefits, and stenting may be of harm just because of the increased risk that happens soon after stenting. So now let's talk about the hip fracture part of the lecture. So just a review of the hip joint. It's really our largest range of motion joint, secondary to our shoulder. It's a ball and socket joint. It's encased by this thick fibrous capsule that allows for a large range of motion. And blood supply is everything. We'll talk more about that. That's something I learned when doing this lecture. How do we pick what sort of surgery we do? And it's all based on blood supply. So if this blood supply is disrupted in the femoral head, you're at risk for developing avascular necrosis. So that's how they choose intramedullary narrowing versus hemiarthroplasty, sort of in a nutshell. So in terms of epidemiology, hip fractures are quite common. There's more than 300,000 cases each year. Of course, age increases your risk. Those at highest risk are white women. Their lifetime risk of hip fractures is 15%. And let's see. So why do we care about hip fractures so much? Because the 1-year mortality is at least 25 to 30%. So a lot of these patients die from their from complications of hip fractures. So other risk factors include history of dementia, osteoporosis, decreased mobility, and other comorbidities. So this is looking at the incidence of hip fractures in men versus women, and it's stratified by age group. Somewhere in the 1990s, around 1992 to 94, the bisphosphonates came out, and we've actually seen a decrease in our hip fracture incidence since osteoporosis started being more widely treated. And this looks at mortality. You can see the highest mortality actually is for older men. They have a mortality upwards of 35% in 1 year. And then this is why we care about hip fractures. So it really impairs people's functional status. So 60% after hip fractures have impairment in at least one ADL that they didn't have impaired prior. 40% are unable to walk independently without assistive device. And 30% have permanent disability, 25% death approximately. So types of fractures, the femoral head fracture is typically in trauma like motor vehicle accidents in young patients. The femoral neck fracture is the highest percentage, or occurs highest in elderly patients with osteoporosis. There's the highest risk of avascular necrosis in this type of fracture because of the disruption of the blood supply. The other fracture that happens more commonly in elderly patients is, let's see, subtrochanteric fracture. And in terms of treatment, so I wanted to talk a little bit about informed consent because we often get this question, someone comes in from a nursing home with a broken hip. How do you determine decision-making capacity? Fellows, you're good at this, I know. Especially you, Dr. Danley.
So first of all, capacity is usually involved for major issues. One is making sure they understand, what do they understand about their underlying medical condition? What do they understand the treatments that are being offered?
Mm-hmm.
Can they understand the risks and benefits? And can they reason logically? And can they also, is it reproducible? Is it something that is
Perfect. So you want consistency in response between interviewers. So when you go in versus I go in, they should kind of be similar answers. Is the patient aware of the fracture and understands the reason for surgery? I mean, how many times have you asked someone, what are you here for? And they're like, I don't know, I think I have pneumonia. And they're laying there with their broken hip. So that obviously is not someone that probably can consent to surgery. Can they give an understandable reason for consent or refusal? Is their decision consistent with prior life events and decisions? And then, of course, you can obtain input from their DPOA, which they hopefully have if there's any questions. So I did want to talk a little bit about non-operative management because it is an option, not a good one, but it may be an option in patients that are severely ill, demented, and terminal, on hospice. I often recommend surgery for palliative reasons, though, even if I know they're not going to walk again. I mean, just simply from a pain control standpoint, oftentimes patients have less pain. And I think it's easier for them to get up in the chair, after they have their hip fracture repaired versus, not. I had a patient in the nursing home once that fell out of bed. She was on hospice, and she was on hospice for failure to thrive. She only weighed like 75 pounds. So she fell out of bed and broke her hip, and her family called once she got to the hospital and said, we don't know what to do. Should we, operate and fix this? And with her, I really thought she wouldn't survive very much longer. So I said, why don't we just, ramp up her Roxanol and let's just keep her comfortable. And she lived for 2 years after that. So I think I didn't choose correctly, but she lived for 2 years at 75 pounds. I think she was like 70 pounds when she died. And she ended up actually being able to stand on that leg eventually. After several months, she was able to at least transfer to the toilet and such. And we kept her pretty comfortable. She was on scheduled Roxanol till she died. So DNR, DNI, and do not hospitalize orders in the nursing home can be reinstated in the PACU. So it's not really a contraindication to surgery. It's kind of confusing sometimes when that change takes place because, of course, no surgeon wants the patient to die on the table. But patients generally do pretty well. I've not heard of anyone here dying, from their hip fracture surgery per se while they're being operated on.
Angela, you can argue that surgeons are wrong. There is no reason if you need surgery not to die on the operating table. It's terrifying for their statistics.
For their numbers.
But there's absolutely no reason why a very sick person, if they die on the table, I mean, resuscitating somebody who's a DNR is quite honestly ethically unacceptable. I've tried to explain this to surgeons, but their numbers are far more important. I know we have a surgeon here can argue on that one.
I actually engaged him in this conversation when I was preparing this, like him and one of his fellow chief residents, and we were talking about this. It's such a gray area. No one wants to take that risk of having the numbers be skewed, but.
It's vice versa. You're as a surgeon, you're in this with the patient, right? This scenario is a little different. But they're making a commitment to you too to kind of see this through to an extent, and it's hard. I mean, when you've got that, it goes both ways a little bit. I get, what you're saying.
So let's talk about what type of surgery is done when. So our options are typically intramedullary nailing or screwing, hemiarthroplasty or arthroplasty. So it all comes back again, like I was saying, to blood supply. If that blood supply is disrupted to the femoral head, then you're going to have to replace the femoral head. So you're going to need to do a hemiarthroplasty. We do total hip replacements, typically only electively in patients that have arthritis. The surgeries are more technically advanced or difficult, and you're under anesthesia much longer, and the rehab is a little bit more difficult. So we tend to do those in young, healthy patients, and the patients that actually have trauma and break their hip, we stick to the intramedullary nailing or the hemiarthroplasty. So I wanted to talk about some best practices in perioperative care because this is really what our hip fracture study was focusing on. So you guys all know this stuff, but the residents did not. So we'll go through each one of these in detail, but our goal for surgery is within 48 hours. We want to definitely provide adequate pain control. We want to focus on early mobilization and, of course, provide good DVT prophylaxis. And then there's always delirium. We got to be vigilant about that and try to avoid it. And then treat osteoporosis once the hip fracture, after it occurs. And then, of course, early planning to rehab or SNF versus home. No one really ever goes home, but Okay, so we know that surgical delay independently impacts mortality. If surgery is delayed by more than 48 hours, 1 month mortality is increased by 17%. So the mortality and morbidity really stems from the immobilization. So patients develop DVTs, pneumonia, pressure ulcers, weakness, depression, just overall decreased quality of life, and further impairment in their ADLs and IADLs. And I think ortho really has worked hard in the last year to try to do everything to fix these hip fractures within 48 hours. I know I've noticed on service that they really are getting to them much quicker than they used to, and they really did some revamping. They had meetings with anesthesia to try to make this happen, and I think they've streamlined their process a little bit, and I think it has gotten better. Have you guys noticed that? Yeah. Because I remember when I first started, it would take days sometimes, like 3 or 4 days often. So pain control is very important. Patients get delirious because of pain, and then they get delirious because of the pain medicines we give them. So my go-to regimen is I start scheduled Tylenol, 650, Q6 to 8 hours on every hip fracture patient. Not PRN. The residents always want to do PRN, but the patients usually don't ask for it or are not given it, so I just make it a routine order. And I really think this cuts down on the amount of narcotics used, that it provides this basal pain control. I often do morphine IV in the first 24 hours, then I try to switch to Norco or Percocet PRN. And then sometimes if I think the patient's not going to ask for it, I'll schedule that too. I'll do like oxycodone scheduled with my scheduled Tylenol, maybe twice a day or something if I think they're not going to ask. Because our goal really is not to have these patients lay there and suffer, of course. Early mobilization. So this has also, I think, gotten a little better. We need to address the weight-bearing status. Sometimes, we leave it up to the ortho residents to put in the order after surgery, but really most patients, uncomplicated procedures, should be post-op day 1, weight-bearing by post-op day 1. So I think ortho is getting a little bit better, although the last time I was on service, the lady lay there for 2 days without physical therapy because they kept saying she had a bed rest order. And all it took was 1 phone call to ortho, and they said, oh yeah, she should have been able to get up. So I had to remind the residents, because I think they all think too that these patients, there's some contraindication for them getting up, and there usually is not. So they looked at a study, because in other countries, Dr. Flaherty talks about this in China, they don't believe that you could get patients up after these fractures. So ortho did a study looking at the rate of implant failure with early mobilization versus waiting a week or 2. And they found that unrestricted weight bearing from day 1 in elderly patients after hip fracture surgery really had the same outcome as waiting longer, and waiting longer has other complications. So this was done in 1996, and I think we've sort of changed our way of thinking here, and it sort of is filtering over to, other places. Dr. Flaherty's been working in China about this, I know. So I want to talk about VTE prophylaxis. I'm still getting a lot of patients in skilled nursing from community doctors and hospitals that are not on DVT prophylaxis, so I think this is one area that we can improve our care. So mechanical devices are great. So SCDs are great, but their data's not great, but they probably are better than nothing. Aspirin's better than placebo, but not as effective as other options. So aspirin plus other anticoagulation decreases clotting, but also increases bleeding. There's a doctor at DePere that always sends patients on aspirin twice a day. That's his DVT prophylaxis. So I get them at Maryland Heights, and I have to think whether that's adequate or not. The risk of DVTs are really high in these patients. Up to 50% will develop DVTs without prophylaxis. And PEs even cause 15% of deaths after hip fracture repair. And of course, the factors that increase the risk of DVTs are pretty much everything our patients have: advanced age, delayed surgery, general anesthesia. This is the big anticoagulation guidelines. Dr. Gamick has talked on these many times, the CHEST guidelines. Basically, what it comes down to is that patients should have some sort of DVT prophylaxis, preferably Lovenox or a novel anticoagulant for 30 to 35 days post-hip fracture. So I always tell the residents I don't really care what they pick. I personally prefer a pill if I can get away with it, because I just think it's more comfortable. I wouldn't want to be laying in a SNF and getting a shot every single day. And I think Lovenox is still expensive. I know it's come down. It's probably like $800 a month or something now, but I think the oral anticoagulants are cheaper. So Xarelto is what I tend to go to if I'm starting it. It's reasonable unless they have a history of bleeding or renal failure. Coumadin, you can use Coumadin, tried and true, whatever your comfort level is, but just do something. The residents also like to use heparin. I'm like, do you want this patient to get 90 shots over the next month? Really?
Yeah, they hurt.
Yeah, 90 shots. I'm just glad they're thinking about it. Okay, so moving on, delirium. So it's the most common medical complication following hip fracture repair, 30% risk. This is what we always get called on for, after surgery. Usually it appears on post-op day 2 to 3. It's a marker of bad outcomes in general, increased mortality, increased risk of needing placement, and increased length of hospital stay. It interferes with PTOT and functional status recovery. So it may not be entirely preventable, but is more manageable if promptly recognized. So these are all things that we know: early mobilization, open blinds, reorientation, making sure they're not constipated or developing urinary retention, minimizing narcotics but providing adequate pain control, minimizing their polypharmacy. It's always a good time to cut back on their med list. And then removing their restraints and their catheters, their oxygen, just detethering them, their tele leads, all this stuff kind of agitates people. And then I think the biggest one that we have not achieved is letting people sleep in the hospital. I don't know how it's possible to give someone a full night's sleep here, but I think this really affects their sleep-wake cycle, and people get delirious because they're only getting 30 minutes of continuous sleep. So a little bit about antipsychotics. So I think we're getting better at this too. I don't know that the nurses are calling. I remember when I was a resident, I was giving Haldol out left and right on 9 North because I didn't know any better. But I think this is better. There's no data that antipsychotics improve outcomes. It likely just makes a patient more sedated. So you've got a delirious patient that's now asleep. Antipsychotics are not approved for delirium, and they may improve behavioral scores, but it's just because the patient's asleep and can't participate. So there's lots of side effects to antipsychotics. We've got sedation, orthostasis. Sometimes they make people worse. There's the cardiovascular risk with QT prolongation and sudden death. So the FDA has a black box warning on antipsychotics now regarding the incidence of sudden death and stroke. So osteoporosis. I also get a lot of patients that sniff that they've had their hip fracture and they're not sent on anything to treat them. So we fixed their hip fracture, but now how are we going to prevent, periprosthetic fracture? How are we going to prevent fracture in the other leg? So vitamin D is one of, I think, the mainstays for osteoporosis prevention, although Dr. Morley and I were talking the other day about, these whopping doses. Patients now are coming on 5,000 units a day and such. So I think there's a happy medium there. In 2009, there was a meta-analysis done comparing vitamin D with or without calcium to calcium alone, and it showed that vitamin D resulted in a 20% non-vertebral fracture reduction in those greater than 65, whereas the calcium groups didn't have that same reduction. Controversy regarding doses, but we generally think 1,000 units should be sufficient. And then no need to check vitamin D levels. Because our assays on vitamin D are not very great. We had that lecture from Dr. McKee, and she sealed the deal on me checking vitamin D levels. Calcium, question mark. So we used to think patients needed calcium. I think the newer studies are showing that calcium is not as useful in increasing bone mineral density. In 2015, a meta-analysis looked at calcium supplementation and calcium from dietary sources and found that it increased bone mineral density only by like 1%, which is likely not enough for a clinical impact. So bisphosphonates, we really should start them on discharge, otherwise they'll never be started. There was the argument, sometimes you'll hear orthos say, well, it prevents bone healing, so they need to wait 3 months or 1 month or whatever. But in 2015, actually someone looked at this and did the study, does the timing of postoperative bisphosphonate administration affect bone union? And the answer actually was no. There was no difference. A review of Medicare data showed that only 20% of patients with a history of hip fracture had had any treatment with bisphosphonates over the previous 2 years. So this is the highest group risk of people. These are patients that have already fractured and are likely to fracture again, and only 20% of them had been treated adequately. So just say no to Foley. So getting that Foley out on post-op day 1 or post-op day 0, it's very important. Sometimes the nurse will say, well, we don't want that urine in the wound. And my answer is, well, isn't urine sterile, and aren't you changing them, and aren't you changing the dressing? I really don't want this patient to get a UTI. So I just want to talk a little about the study. You guys all know about it. It's actually, we just completed our enrollment. Last month we enrolled, I think it was finally 22 or 23 patients, and now we're just kind of in the maintenance phase. We have 1-year follow-ups coming up with the patients. It started last March, so we're getting ready to start those. And our goal in this study is to look at major adverse events in patients who are receiving usual care versus those who are seen by geriatricians. I'm really hoping we'll see some change, some good outcomes, but I had some difficulty getting the patients on the geriatric service. That was my biggest challenge. I thought it was going to be ortho operating on the patients within 48 hours, but they got their stuff together and they managed to really make a change in that area, and I, for some reason, could not navigate the politics of getting patients on ACE. And that's it. Any questions? I don't know how to turn the lights on. Let's see. You stayed awake, Dr. Morley? We probably slept some. He was awake? Okay.
I didn't sleep for once. You're getting better, Angela. You can keep me awake.
So one of the questions that my team had, or at least posed, when we had a hip fracture last week, and I mentioned putting the bisphosphonate, on their bed list. They said, well, the patient's whatever, 95 years old, so why should we do this? I said, well, how long do you think they're going to live? If you think they're going to live for a year, then
It's worth it.
says there's fracture reduction. So why would you not give someone something that could still help them in a year?
I think I haven't seen really the harm from bisphosphonates. Maybe I don't know if you have, Dr. Morley. I haven't seen the harm, so to me, there's probably little harm and more benefit,
So-called harm from bisphosphonates are these distal femoral fractures, but you have to take it for 10 years
Right.
before
But
you.
even then, you have many more hip fractures in people. It's one of the fantasies of people who want money to study a very rare condition.
It's a very rare condition.
Extraordinarily rare.
Like what is it, the jaw osteonecrosis or whatever? Like no one's ever seen that before, but yeah.
And usually you have to have teeth back to get that. By the way, I just want to make sure I had someone actually send a person to dental clinic before they got started on bisphosphonates, and the person didn't have any teeth. There was no periodontal inflammation. You don't have to refer them if they have good teeth.
You probably wouldn't care if they don't have teeth. I mean, there's.
Dentists should look at everybody before they get bisphosphonates and fix whatever they want to, because after that, you would like the dentist to keep far away from them, because that's where you get into trouble.
That's right.
So part of the routine should be, if I'm going to start a bisphosphonate, see the dentist. After they've done that, then you can go on bisphosphonate.
So,
The bisphosphonate can also adjunctively prevent tooth loss in somebody who still has tooth.
that's, the only other issue I can think of is people with chronic renal insufficiency. They can't take bisphosphonates for
So there's absolutely no data that what you just said is true. The only data that exists is when Merck did their study, they only went down to a creatinine clearance of 30. All the data suggests that people with renal failure, even on dialysis, have much more osteoporosis fractures than they have anything else, and very rarely do they have low bone turnover. So if you're worried about giving it to someone who's got renal failure, you measure the stupid markers, and you can look at them. When I was young, we used to actually biopsy them and see if they had low bone turnover. I think I had 1 out of 100 people that I bone biopsy. It was very rare.
The only real reason that you cannot give bisphosphonate is somebody with either scleroderma or other.
What about esophagitis? One time I didn't because the person had esophagitis,
Then you
but
give IV. I mean, I'm giving this talk in a month's time, but then you give IV. Okay, so zoledronic acid works very well if you remember to give.
how do you order that? I've had patients ask, like who? Okay.
What you've got to do is remember to give them Tylenol for 2 days before and a day after, otherwise they get terrible fevers and they won't come back. They feel like they've got flu. They get flu. They get what looks like flu. It's not flu, but it looks
So you guys get tripped up on like this argument. When I gave this to the residents not too long ago, their whole thing was the whole cardiac clearance. They just couldn't, like, how can we not get that echo? How can we not? That was the thing that they had the hardest part with this lecture. But it's just funny. It's
Most residents want to be cardiologists.
right.
They don't understand that cardiologists are fundamentally useless for about 95% of things. 5% they're good at. Unfortunately, they're very bad at syncope, which is most probably 4% of the 5% that you need. I'm exaggerating, but realistically, and in your case at the beginning, the one question always is, could it have been syncope? People don't know when they faint, so you've got to accept anybody who falls, unless somebody watched them and they were awake all the time, could have had syncope. And it's about a third of people who fall have syncope.
I
Which is why
tried to
it's
get somebody who actually syncopized in clinic and then did it again at the admitting desk. Like witnessed twice within less than an hour. Cardiology wouldn't take her because she was
they
over
should.
75.
It's no use sending people to cardiology because without the arrhythmia service, they have no idea what to do. Most of these people should never get admitted. They should go home in the red recorder from the ED because that's really what you do, and they get followed up by the arrhythmia people. There is no reason, unless you have had an MI, to admit somebody with syncope. I mean, just and that's the literature, that's the recommendations.
Unless you send it to your phones, you won't know.
Well, you get an EKG and you do the
That's
test.
no good, John. It's somebody with a pacemaker.
Well, they don't have pacemakers, most of the people with syncope. If they're having syncope with a pacemaker, they need an arrhythmic doctor because there's something wrong with their pacemaker.
Anything else?
I'm just telling you that they don't need it.
Do you guys want to take this outside?